Welcome to the Pod of Inquiry, pushing the envelope for human understanding and optimization, the podcast for podiatrists. The Pod of Inquiry is designed to empower you with knowledge. What happens from there is up to you. Your host, Dr. Stephen Barrett, has designed this show to take you down some very deep rabbit holes, hopefully bringing you back out again, relatively unscathed, but cerebrally whipped, enabling a better understanding of all things worthy of inquiry. If you have more questions after the show, then that is good. The new discovery today many times was the new discovery 50 years ago, only to be suppressed or plainly ignored. Medicine and surgery can sometimes take a long while to get their paradigm shifted. We hope to have a lot of fun on this show and maybe destroy some ridiculous dogma along the journey. Thanks for joining the show today. Let's start spelunking.
I'm really excited to introduce you to my guest today, Dr. Scott Martin. Dr. Martin is an interventional pain management specialist who completed his fellowship at the University of Michigan. We talk about perineural infiltrations with different regenerative techniques and some of the things that he's doing that are really cutting edge out in Las Vegas, Nevada. I think you'll find the interview very fascinating, as did I. So please enjoy this conversation that I have with Dr. Scott Martin.
All right, everyone, I've got Dr. Scott Martin coming on the show today, and we're going to talk about osteoarthritis, which is going to destroy a little bit of the dogma, I think. So before we get started on that specific topic, Dr. Martin, why don't you tell us how you got to the regenerative space and what you do as a pain management physician? And just give the audience a little bit of background on yourself, if you'd be so kind.
No, I'm humbled. Thank you very much for the opportunity. So by training, I'm a board-certified interventional pain doctor, and for about 10 years, I practiced in Southern California, and I was very busy. 30% of my practice was oncology. These are folks in the very, very latest stages of disease. This is both adults and children. The kids were in particular hard. That was terrible. 30% of my practice was oncology. Like I said, 30% was narcotic addiction. I did a lot of detox. I took care of a lot of very, very sick patients on very, very high dose narcotics at the height of the narcotic epidemic. Then 30% of my practice was trauma. I practiced at a level 4 trauma center in Mission Hospital, and I was the go-to guy at any hour of the day, any day of the week for folks that had gotten run over and had open book pelvic fractures, plus needed back surgery, and went into the hospital on 120 milligrams of OxyContin 3 times a day, plus oxycodone 30 milligrams 6-7 times a day, plus Valium, plus mood stabilizers, plus antidepressants, plus sleepers, plus gabapentin, plus. And this is before they even hit the door of the hospital. I did that for about 10 years, and I just burned out. I was at the hospital at 5:30 in the morning, 6 o'clock. I didn't get home until 10:30, 5-6 days a week. I never saw my wife, never saw my kids. Went on vacations that I don't remember being at personally, but have pictures of. And we moved to Southern California. From Southern California to Nevada. And within a year or two, I opened the first non-narcotic pain practice. And when I opened the first non-narcotic pain practice, I started getting very heavily into personal injury. And the personal injury space was unique because I didn't write narcotics. Attorneys and providers were looking for a level of medical benefit that superseded just steroids and pain pills. It's not what they wanted. They actually wanted their folks to get better. And I was working with a group of attorneys that weren't interested in, padding cases, weren't interested in, the most expensive procedures. They wanted to see their clients get back to their former quality of life. And this is when I first started to use biologics. We were using exosomes for post-concussion syndrome and getting brilliant results. We were using PRP, we were using bone marrow aspirin. We started using Wharton's jelly for rotator cuff tears and tears of muscle and fascia, for, traumatic injuries in joints. And I continued that through COVID. And during COVID, started a telemedicine company, but got offered a position to be an executive in a biotech. And that's really where my whole mindset and practice paradigm shifted fairly aggressively. I moved an entire family, and I moved house to the Panhandle of Florida. And for about a year, worked for a biotech and took 7 articles to publication, talked to probably 60 doctors a week, and got heavy into literature. And that set the foundation for what I do now. And at this point in time, I have a regenerative aesthetics practice, which is very, very rewarding. I serve as a medical expert in the field of regenerative medicine at the federal level of appeals for doctors who have clawbacks from Medicare for using biologics. And I consult for 3 or 4 biologics companies, and mostly do physician education. I dedicate about 15 hours a week to physician education, and that's been one of the most rewarding things I've ever done.
Very interesting. It's funny how the path of practice and career and life sometimes takes a course that you would never be able to imagine to start off.
Indeed it does.
So let's talk about osteoarthritis. I think you have some interesting things to let us know and educate us about that.
So when we look at the United States as a patient, if the United States was a patient, we have some growing trends. Right now, as we sit today, around 46% of the U.S. population is diabetic or pre-diabetic. And just about the same number of folks have osteoarthritis. And we've seen this cataclysmic change almost where the standard bearers, the what was considered the standard of care for osteoarthritis, these giants are literally getting chopped down. And I don't mean that in a small way, I mean that in a big way. And what do I mean by these giants are getting chopped down? Well, forever, the Goliath of the industry was steroid. In 2020, an article came out in Radiology, and it proved that steroids can actually accelerate degeneration of joints. Well, that took everybody by surprise.
Well, when you say accelerate you broke up just a little bit. Accelerate the degeneration of joints?
Literally. Yeah. That it wasn't helping joints, it was actually accelerating the degeneration of joints. And for years, in pain medicine, you could give kind of 6 injections a year. Then it was encouraged you could give 4 cortisone injections a year. Well, if you're a pain doctor and you're doing injections, you're doing maybe your 4 or 6 a year. But you're also getting steroid shots from your orthopedic surgeon, you're getting them from your primary doctor, maybe you're getting them from a podiatrist, maybe you're getting them from a rheumatologist. So you're not getting 4 or 6 cortisone shots a year. You could be getting 15, 20 cortisone shots a year because there's such poor communication between providers. So these studies were only couched on folks getting 3 or 4 injections a year. Some patients are getting 15, 20 steroid injections a year. And now we know that repeated administration of glucocorticoids and steroids to the joint actually accelerates degeneration of the cartilage.
Very good.
Well, that was kind of giant one to fall. Not a week ago, a systemic review article was brought. And that article proved that hyaluronic acid has 0 benefit in osteoarthritis. 0 benefit. So now your big 2 kind of treatments for osteoarthritis, your 2 giants in the industry, hyaluronic acid, which has now been proven to be actually worse than placebo for patients. In this systemic review, they were able to prove that there were more adverse events from hyaluronic acid injections than there were with just injections of normal saline.
And was that due to a chondrolysis?
I don't recall specifically, but I believe that was part of it.
Well, that takes steroids and your usual, let's call it joint jelly on the picture. There were your two giants right there.
So what else is in the picture, right?
Right.
So what else is in the picture is NSAIDs. NSAIDs have been talked about forever. They are the mainstay of conservative care for joints. Well, the best literature we have on NSAIDs comes from a study performed in 1999, published in around 2012. And it looked at all-cause mortality for prescription NSAIDs. Now, these were only NSAIDs that were given to people with inflammatory arthropathies. And at the time, they believed that the mortality rate extrapolated out was around 16,500 patients a year. How many people die every year from narcotic overdose deaths? Around 70,000. So maybe NSAIDs are safe, maybe they're not. But if you look at NSAID-related deaths across all factors in prescription and non-prescription associated deaths, that means every GI bleed that eventually led to death, every renal failure that eventually led to death, every cardiac event in patients that were on prescription or over-the-counter NSAIDs that eventually led to death, every hemorrhagic stroke that eventually led to death, intimal damage from NSAIDs that caused heart attacks or caused strokes that eventually led to death. We believe the numbers are more like 250 to 300,000 patients a year are dying. And at the time of death, we're either on prescription NSAIDs or on over-the-counter NSAIDs on a regular basis. That means more than 3 times a week. So your big mainstays for osteoarthritis care, other than just diet and exercise, and we know that diet and exercise isn't working that great because 46% of the U.S. population is obese and they're diabetic, right?
Right.
Your other mainstays, NSAIDs. Soft numbers, maybe 50, 80,000 people die a year. Realistic numbers, hundreds of thousands die a year from NSAIDs, right? And then move into the procedural recommendations from the Arthritis Society, from the American College of Rheumatology, right? Number 1 is cortisone. Number 2 is HA. Well, when you look at these guidelines, what else is in the guidelines? And this is fascinating. The American College of Rheumatology just came out with clinical practice guidelines and recommended 4 joint replacement in patients that were over 100 pounds sooner than later. Okay. The non-union rates with doing a joint replacement on a patient that's more than 100 pounds overweight is staggering. The mortality associated with doing a joint replacement on a moribund patient who's overweight, just from an anesthesia standpoint, is substantial. So, number 1, I don't understand these guidelines. And number 2, I think that osteoarthritis is sorely misunderstood.
Okay.
And the reason I think it's sorely misunderstood is because we're treating a non-inflammatory disease process as being inflammatory.
That's very
osteoarthritis isn't inflammatory. It's a non-inflammatory disease process.
Is there a component of inflammation at the initial onset and then it progresses more into a non-inflammatory state?
Well, I mean, it's a disease. It's a systemic disease. Nobody just has osteoarthritis of the left knee. They have osteoarthritis of the left knee, the right knee, both ankles, both elbows, shoulders, cervical spine, thoracic spine, lumbar spine, sacroiliac joints, right? It's systemic. But it isn't always inflamed. Your arthritis doesn't get inflamed until you inflame it. You may have osteoarthritis in your back, arthritis of the facets, arthritis of the SI joints. You may have arthritis of your knees, degenerative cartilage, osteophytes in the knee joint itself. But until you decide to pick up pickleball at the age of 62 and you've never played before, you may not irritate that osteoarthritis. Okay. Now, when it becomes inflamed, there's a reason there to use NSAIDs. There's a reason there to use glucocorticoids or steroids, right? But traditionally, what do? And this is where the paradox really meets the road. In the field of regenerative medicine, we have had allografts at our disposal for almost 100 years. Right. For 100 years, doctors have taken tissue from one part of the body and placed it in another part of the body. And right now, we have access to multiple different allografts. Autologous, meaning PRP, bone marrow aspirate stromovascular fat, and allogeneic, in particular, Wharton's jelly, which is derived from the umbilical cord. And there is this tremendous consternation in the market. Now, I know why the consternation exists. Just out of curiosity, how much do you think the fair market value is for osteoarthritis of the knee in the United States annually?
Well, if you're including total knee arthroplasties?
No, non-surgical. What's the value of non-surgical management of osteoarthritis of the knee in the United States annually?
I would think it'd be astronomically high, but
it's a $10 billion a year market.
And that's just non-surgical.
Non-surgical. $10 billion a year market, non-surgically.
Where
and so I have no idea. Okay. But ballpark on knee operations per year are on the order of 1.2 to 1.4 million joint replacements annually. That doesn't include arthroscopies. That's just joint replacements.
Right.
So at an average cost of about $40,000 a joint replacement, you can do the math. Billions of dollars in joint replacements. So when you have a market that's that valuable, a $10 billion market, you're going to get competing interests, right?
Right.
And so there isn't any question that allogeneic allografts and autologous allografts are better than steroids, are better than hyaluronic acid. There's no question about it, right?
Right.
The issue comes when doctors try to market these in the face of FDA regulations. And this is where it gets sticky. And this is where I do most of my work, right? And this is kind of where the rubber meets the road for the entire osteoarthritis marketplace. If a doctor were to tell a patient, you have osteoporosis, your bones are weak, and I need to give you calcium, magnesium, and vitamin D to supplement your bones so you don't break them. Right. Everyone generally understands that. Everyone accepts that, right?
Right.
But people find it hard to accept that if I gave you growth factors, if I gave you type 1, type 3 collagen, if I gave you hyaluronic acid, if I put in your knee, I applied an allograft to your knee, I applied the building blocks for cartilage regeneration to your knee. Not that the stem cells would magically heal your knee, that your body has the ability to heal itself. But if you don't have the right building blocks, it can't do that. Your bones have the ability to get stronger, but you have to have the right building blocks, the right supplements for your bones to heal. The joint's no different. The joint is no different. A cartilage-based defect in the knee, degeneration of the knee joint, cartilage. If you apply the right building blocks to that, and you give the body time, the body will heal itself.
Now because there's been the dogma that we can only repair these condylar defects with fibrocartilage and not get a regrowth of hyaline cartilage. What's the situation?
Well, So interestingly enough, fibrocartilage, fibrin, right?
Right.
We especially from wound care, talk to any podiatrist, they know fibrin like it's the back of their hand, because fibrin is the lifeblood of any wound. Because if you don't get fibrin, you don't get a clot, you don't have an environmental barrier. But fibrin is broken down by the body in 4 to 8 weeks, and the fibrin is replaced by extracellular matrix fibers, collagen-based extracellular matrix fibers. And the discussion hasn't moved past stem cells and regeneration. And where it needs to get is chondral differentiation, because ultimately that's what we're looking for. When we're looking at the body healing itself, we put in PRP. What happens when you put PRP in a joint? PRP causes an inflammatory response, but there are fibrin-based growth factors in that PRP. And it isn't stem cells in the PRP that does any magic. What happens is the body's own mesenchymal stem cells from bone marrow, from blood, from fat, migrate to the area. And depending on the building blocks that are there, it builds a house. That house just ends up being the cartilage in the knee joint. And so if there's fibrin there, you get fibrin-based differentiation. Your own mesenchymal stem cells go through fibrin-based differentiation, and they become fibrin, which unfortunately gets broken down in 4 to 8 weeks, because that's what happens everywhere in the body. Conversely, if you apply an allogenic allograft that has chondral-based growth factors, Wharton's jelly, when the body's own mesenchymal stem cells migrate to the area, those mesenchymal stem cells go through chondral differentiation, become chondroblasts, become synoviocytes.
Right.
And the body starts to heal itself. But that's not sexy. What people want to think, and what doctors have been selling for years, and this is where everybody runs into issues with the FDA, is that magically I'm going to give you stem cells. And the stem cells are just going to magically know where to go, and they're just going to generate cartilage, or generate a liver, or generate new eyes, or generate intervertebral disc. The hard truth is that a healthy body is able to heal itself. And you have to exercise regularly, you have to diet, you have to fuel your body appropriately. You have to replace amino acids, you have to replace protein as you get older. And when you injure yourself, even if you put the right growth factors, the right chondral precursors into a joint, if the body isn't healthy, the body's not going to heal itself. And this is the ugly truth that people don't want to hear. People want to hear, well, if I go to Costa Rica and you give me a $30,000 shot, my body's just going to heal itself. It's not the case.
Right. It's kind of analogous to hiring a great painter to come in and paint a portrait of your family, and you give them the worst piece of canvas possible. And
I love it.
So
absolutely.
Right. How can you expect greatness if you don't have a foundation to allow for greatness?
1,000%. 1,000%. And so, where I think we have gone astray in the whole arthritis conversation, and this happened horribly through COVID, right? We de-emphasized exercise. We de-emphasized appropriate and healthy eating because you couldn't get fruits and vegetables in the grocery store. What was open? Fast food restaurants. McDonald's was open over COVID, right? Taco Bell was open over COVID, right? You could go and you can get frozen pizzas, you can get fish sticks, you can get all sorts of candies and stuff like that, but you couldn't get fruits, you couldn't get vegetables, right?
Right.
Couldn't get meat. And no gym was open. And if you went outside just to even take a walk, you had to be 6 feet from somebody else, and you carry, a 6-foot stick so you didn't run into somebody else. If you're out surfing in Southern California, you got arrested
Right.
for being out in the water by yourself. right? Better chance of getting eaten by a shark than getting, COVID out surfing in the middle of whatever, Blackies in San Diego by yourself than getting COVID. And unfortunately, this is what our society's become, right? We want our healthcare like we want our food. We want to write a check for $10 and we want our Big Mac extra value meal. And if they don't fill our soda up all the way, and if the fries aren't extra salty, and they didn't put enough French fries in the thing where they're spilling over, we're upset, right?
Right.
The hard truths are that the giants that were going to fix osteoarthritis for us, the steroids, the NSAIDs, the hyaluronic acids, they don't work. They actually make us worse. It's the Davids out there, not the Goliaths, the Davids that allow you to actually heal. And the Davids out there are 15 minutes of exercise twice a day, sensible eating habits, right? Maintaining a healthy weight, going to bed at a fixed time at night, getting up at a fixed time every morning, right? Fueling your body, taking supplements as you get older, adding essential amino acids to your diet if you're going to exercise and you're over the age of 50, adding protein to your diet, more protein if you're over the age of 50. And if you have injured yourself, as opposed to, wishing on a golden star or, wishing on a magic shot or believing a doctor is going to charge you $30,000 in some back alley in Costa Rica, why not use what's been used for 100 years and go see an expert in the field of regenerative medicine who will actually tell you the truth? Right. That your body has the ability to heal itself, but your body has to be healthy, number one. And number two, we have to put in the appropriate building blocks to get that done.
Well, there's some problems inherent in that. And I agree with you 100%. You talk about all of these, what I call the 4 pillars of health: good nutrition, exercise, good sleep, and then some component of spirituality or however you want to categorize that. But interestingly enough, if a patient will buy in on those 4 pillars, all of a sudden the condition that you are specifically treating or I'm specifically treating may enhance and get better. But then all the time they'll say, I had this other thing that's better. I had this psoriasis went away. All of these crazy things because you've given the body a chance to heal itself.
It's interesting. In all of the osteoarthritis guidelines, there's not a single element offered about an anti-inflammatory diet.
Right.
Nothing. There's nothing about anti-inflammatory diet.
Now,
there's just diet and exercise.
Interestingly, I have a lot of folks that have very complex neuropathies, and some of them are they're lit up all of them. Every square surface area of peripheral nerve seems to be on fire on these 4 clicks.
You betcha.
And what I've done in a couple of cases, we talked about the carnivore diet. And it's a very hard diet. I tried it. It's hard to just eat meat, fish, eggs, and cheese. But I had a couple of people actually do this, and it wasn't because of osteoarthritis. It was because of their inflammatory neuropathy. And interestingly enough, they did get much less inflamed. But they also said, I had some joints that hurt. They don't hurt so much.
And now a message from our sponsor. Well, folks, if you're over 40 and you're not using a supplement to augment nitric oxide production, you should really rethink that. This molecule is absolutely imperative to health, not to mention the cardioprotection. Nitric oxide is a physiological molecule that does so many things for your health. I never miss a day of nitric oxide supplementation. That's how important it is. Long overdue, there is now a nitric oxide replenishment formula without the fear of oxalates. Approved Medical Solutions does not use beets, spinach, or arginine. Approved Medical Solutions is proud to offer our audience their oxalate-free nitric oxide formula. If you are not a healthcare provider, you can still get started by going to approvedmedicalsolutions.com and use the code SBarrett at checkout, and you will receive a 10% medical discount savings. For licensed practitioners, just go to approvedmedicalsolutions.com and register. They have unique bundles for all of the full-fledged spelunkers of the Pod of Inquiry. Use Pod of Inquiry at checkout after registration, and I am certain you will be pleased not only for yourself, but for all of your patients. Here's a little secret. If you order their testing strips and test every patient for a few clinic days, you will see that nearly every one of them will be deficient. When they see this result, they will want you to start them on it immediately. Now, thanks to Approved Medical Solutions, you can give them the best care without the worry of oxalates. Thanks for watching. You can start today.
Look, I would argue that neuropathy is almost autoimmune disease. If you get autoimmune disease, I liken autoimmune disease to sisters, skipping to church or skipping to school. They're all kind of holding hands. I had very few patients that had lupus that didn't also have inflammatory neuropathy and inflammatory bowel disease. I had very few patients that had Graves that didn't also have some issue of inflammatory skin disease and some issue of inflammatory joint disease. When you are overweight, when you do have significantly elevated levels of blood glucose, you are now in an inflamed state. And in that state of inflammation, the first thing that goes is the outer third of the nerve. That is a neuropraxic defect. There are 3 layers around the nerve. You've got the inner layer, the endoneurium, the middle layer, the perineurium, and the outer layer, the epineurium. Well, the epineurium, interestingly enough, is dense irregular tissue. It's collagen-based. So when you see folks with degenerative joint disease that is inflammatory, is, non-inflammatory, depending on how they treat their body and how they fuel their body and how they supplement their body, you find that same degeneration in the nerves, cartilage-based degeneration in the nerves. That's the first heralding sign of neuropathy. Numbness, tingling, abnormal feeling to your feet or your hands in the shower. What is hot water feels ice cold. What is cold water feels burning hot, right? Those are neuropraxic defects, all right? Remodeling the inflammation in your body by adopting an anti-inflammatory diet, by supplementing, in any and all manner, growth factor complexes, these type of things. It doesn't just improve joints. It can improve neuropraxic deficits. When I was working at this biotech, we had a group of doctors that were completely invested in neuropathy. And they were just very frustrated by the results. And they tried everything. And so I said, look, I want you to try an allogeneic allograft, and I want you to apply it twice. But we're going to be very regimented, very scientific about this. I want you to get a nerve conduction velocity study across the perineal nerve, which is a nerve kind of in the upper outer leg, and across the tarsal tunnel, which is a nerve region in the medial ankle. And the nerve conduction velocity looks at how fast information travels, how fast information is traveling down the nerve. And I want you to do a monofilament test, meaning a test to see how sensitive their skin is. And they did this, and they recruited about 40 patients over the course of 2 years. And what they found was when they applied an allogeneic allograft, they put cartilage-based building blocks around cartilage-based defects in those nerves. And that's all they did. They didn't change diet. They didn't change anything else. They were able to objectively measure a near 40% improvement in nerve conduction velocity in 38 of the 40 patients. Monofilament testing improved 43% in 39 of the 40 patients. And that correlated with a symptomatic improvement in those patients of around 46% in almost 95% of the patients. It was a phenomenal observational study.
So how are they applying that, Scott? Would they just like a perineural?
Perineural.
Okay.
Perineural application, infusion of biologic. they liked to use a cannula. They used an aesthetics cannula, a blunt tip aesthetics cannula, to make sure that they weren't going to actually hit the nerve. So they were perineural, and they're literally dropping cartilage-based, collagen-based growth factor complexes around cartilage-based defects in the nerves that they knew were there based on nerve conduction velocity testing.
So since I brought up the topic of application, there is some confusion, and I really don't know for myself. And I'd love to hear from you as an expert to kind of clarify my thought process on this. But you'll hear people, let's say just for the knee, let's say osteoarthritis of the knee. There'll be a lot of people will put it intra-articular. Other people will actually put it in the subchondral bone. And some people will do both. What's your thought process on that?
So we're going to back out a little bit because we're talking about allograft application, all right? And I think this is very important. Now, 2 weeks ago, the state of Utah approved a law that said that any doctor in the state of Utah can apply stem cell products, and they use the term stem cell products, even if they're not FDA approved, in the course of practicing medicine in the state of Utah. And this is very, very important because in this realm now, whether we're talking about neuropraxic deficits, whether we're talking about cartilage-based defects in joints, all right, where steroids are no longer gold standard, where hyaluronic acid is no longer gold standard. If anyone made the effort to look at true mortality associated with NSAIDs, they would find that it overwhelms narcotics more than you could possibly imagine. So what is left? What's left? And what's left is the application of allografts, both autologous and allogeneic. Every doctor in the United States has the ability to practice medicine and use products off-label.
Correct.
Gabapentin. Gabapentin is prescribed more than any other drug in the United States.
Well, there's two exceptions to that. There's the two drug exceptions of using off-label, and that would be hydroxychloroquine and ivermectin.
That absolutely, right?
But also, you saw where the FDA tried to do that, the war.
Absolutely.
Right.
Until now, and now we know that they help with COVID, and now they're no longer contraindicated if somebody has COVID or long COVID, right? My point being that gabapentin and ivermectin were written off-label almost 90% of the time.
Right.
All right? That doesn't mean it didn't work, but it was off-label and a doctor can practice medicine. And so when we talk about applying allografts, and there's some very big thought leaders out there, Chris Centeno, some others, that have echoed the same, right? That if you're looking at applying allografts, the doctor can apply an allograft, whether it's allogeneic or autologous. They just cannot make claims when they do it. In the field of regenerative medicine, no biologic, whether it's autologous or allogeneic, can be used to diagnose, treat, prevent, or cure a disease process. And this is where it gets interesting. So if I write in my chart note that I applied an allogenic allograft to treat osteoarthritis, osteoarthritis is a systemic disease process. You need a drug to treat a systemic disease. And if I just gave you an allograft in your left knee, would it be reasonable that all of the arthritis in your body got better? That, cervical stenosis from osteoarthritis suddenly got better because I put an allograft, any allograft in the left knee? Of course, it doesn't make sense, right? And this is where the FDA has come down on doctors for making claims that stem cells were going to cure you, right? That stem cells were going to regenerate cartilage, right? But that does not preclude a provider, any provider, from applying an allograft as long as they're applying the allograft to a cartilage-based defect. And they say what they're doing. Allogenic allograft, autologous allograft applied to cartilage-based defect in the left ankle, as noted on MRI from 3/1/2023, demonstrating subtalar joint degeneration.
So let me go back then about the point of application for, let's say, osteoarthritis.
So in the correct.
Right.
So building block specific application is what I would encourage. If it is an osteochondral defect, you want to put in building blocks that are going to go through osteoblastic differentiation. You should be using BMAC. You should be using bone marrow aspirate concentrate and applying it to the bone-based defect. If it's degeneration of the cartilage, you should be looking for chondral differentiation and selecting an allograft that is most appropriate, has the building blocks, collagen type 1, collagen type 3, hyaluronic acid, namely something like Wharton's jelly, that is going to go through chondral-based differentiation. It is this level of specificity that every podiatrist knows and every orthopedic surgeon knows. If they're going to do an allograft application, if they're going to do a tendon transfer, they're going to use like tendon or damaged, deranged, degenerated tendon. If they're going to do, a specific transplant, and they're going to do nerve transplant, well, they're going to harvest similar nerve. Or vascular transplant, they're going to harvest similar vessels, right?
Right.
They're using appropriate building blocks for whatever they're trying to get the body to heal. And this is terribly important. You can do a tendon transfer. The body still has to heal itself. You did the surgery, but if the body doesn't heal itself and accept the surgery, you got a bad surgery.
Right.
Right? So you can do.
So, I guess what I'm asking is, where's the truth between an intra-articular application versus an intra-articular and a subchondral intraosseous application, or just an intraosseous subchondral administration? Because I heard this debate, and I don't know. I don't know the right answer to this.
My answer to that would be,
yep,
it falls completely on your level of training and expertise. If you've done 4,000 intra-articular applications, you should do intra-articular. Even if intrachondral or subchondral application is better, if you haven't done it and you have been trained to do it, you shouldn't do it.
Well, that's completely sound advice for anything, right?
Right, absolutely.
Right.
If you've never done a nerve wrap or a tendon wrap, or you shouldn't do it, right? If you've never done a decompression of the tarsal tunnel, you shouldn't do it unless you've got somebody standing over your shoulder who has done it. I think we've gotten away from the tenets of medicine: see one, do one, teach one, right? Now it's rep tells you that she's seen one, you should do one, and the next patient's going to be your first, whatever, experiment. I mean, there's all sorts of great training out there. There are all sorts of really great doctors that are dedicated to medicine that will offer their time for you to sit on their shoulder. And maybe it's not hands-on, but you shouldn't start with hands-on anyway. You should get the theory. You should know where the pain points are going to be. You should know where the danger zones are. You should know where no man's land is. And then you should do your hands-on training. I mean, this is why fellowships exist.
Right.
But there's so many interesting and esoteric things that people are doing now that were never taught in fellowship that you have to get post-fellowship. Spend the money.
Well,
go take the training.
Yeah, I think too, it's that, a lot of people talk about, I want this guy, he's right out of residency or fellowship. And that's really great because you have usually a young mind that's thinking about the body, a clinical experience is really unbelievably valuable. And after you've done things for 15 or 20 years, you've made observations that could have never been, inculcated into you during a formal training program.
I think the young gun out of training is a specific entity. A young gun out of training with experience in Da Vinci robot for prostatectomy, all right, who went to fellowship where Da Vinci robot was taught first. Okay, that's probably somebody you should see for a prostatectomy if you want a Da Vinci robot prostatectomy, right?
Right.
An endodontist that's using, robotic dental implants, right?
Right.
And they're right out of training and they trained on this robot. Okay, great. Probably better, much faster loading time for dental implants than just open surgery. Far fewer risks of infection and dry sockets and everything else, right? That's very different than somebody who goes to see a doctor and they've had 4-foot surgery, a toe amputation, they're diabetic. There's a potential pseudoarthrosis of a 4-foot fusion, right? And you're looking at, collapsed metatarsals and potentially a tendon rupture, and it's going to be an extensive podiatric surgery or orthopedic foot surgery. You should not be going to a guy straight out of training, right? Because
that's
100%.
Yeah,
they don't have the breadth of experience to know what's going to happen wrong.
Right. Well, and here's the interesting thing. Are you familiar with the Dunning-Kruger effect?
I am, but
so
please.
So the Dunning-Kruger effect, I think it's very great because on the x-axis it's spinal experience, and on the y-axis it's the level of your certainty of how something's going to happen. And the highest point on the Dunning-Kruger curve is with the least experience. And even the most esoterically great trained individual is going to have a higher feeling of himself, for lack of a better way of put it, at time zero than when he's out at 10 years or 20 years post experience or post the beginning of that experience. And the psychologist refers to that initial high spot on the extreme left side of the x-axis. It's Mount Stupid, because you don't have enough experience to really know what's going on. It's like we so far on Mount Everest, the hair's very thin, and you're deluded because you just think that everything's gonna work like it's supposed to. But then that clinical experience over the x-axis as you go out in time, all of a sudden humbles people quite a bit.
Sure. Well, you don't know what you don't know.
Exactly.
Because you haven't seen it.
Right.
When I was in Mission Hospital, I had a crew of guys that were all my good friends. And all my good friends were the guys who were in the hospital on a Thursday night or a Friday night at 10, 11 o'clock, waiting for trauma to move through so we could do an elective case that was scheduled at 2 or 3 in the afternoon. And these guys kind of were my crew because they were my people, right? That there was so much dedication to patient care that it didn't matter what time, day or night it was, we're going to try to get these folks better. We've lost a lot of that in medicine. We just have. I think that, there have been so many great, promising drugs that were going to make patients' quality of lives better that turned out to be side effect nightmares. There were so many great procedures that were going to dramatically improve clients' quality of life that ended up just being boondoggle. Complete meniscectomy. Complete meniscectomy of the knee was sexy for a while, right? Every orthopedic surgeon was doing this.
Right.
Well, it didn't help the patient. The people that really helped were the people who were doing the surgery, because 3-6 months later, they got a knee replacement. And as medicine evolves, we find these things. But, kind of circling all the way back to the beginning, we have a population of patients that are less patient, are less healthy. Patient meaning that they're less contemplative. They want to be better right now, right? And they didn't get sick right now. They've been sick for a while.
Right.
they're less healthy, they're less dedicated to their health. And in all fairness, things like GLP-1s are not helping, right? The whole GLP-1 craze where I can take a shot, right, and I can still drink half a bottle or a bottle of wine every night. I can still go to McDonald's 2-3 times a week. I can still have 2 Krispy Kreme donuts a day, and I'll still lose 2.5 pounds a week. Right. That I don't think is a good thing. And although people are looking at the scale, they don't realize that they're getting sarcopenia. They're getting Ozempic face where the face hangs. They're losing their hair, right? They're losing their eyelashes and their eyebrows. Their skin integrity is terrible. All of these things are bad because any shortcut to health is just that. It's a shortcut.
Right. Well, and we're in a society now that there's many, this could be a discussion in and of itself for probably a 10-hour podcast. It's almost like for patients that know the least, expect the most. And there's this perception that there has to be this magic pill that I can just stay. I don't want to have to work. I don't want to have to really put my heart and soul to try and turn this thing around with a physician. And so it makes your job, our job, much more difficult.
Well, but I mean, I think this is what's happening in medicine. And I agree with that. And I think we're moving gradually. I trained in England. My third year of clinical training was in Kingston upon Thames, at one of the Royal College hospitals there in London, outside London. And they had a 2-tier system. Everybody went to national health system that just had standard insurance, right? Right. But almost every surgeon, almost every doctor had a private day. And on that private day, they saw patients cash. Well, this secondary market is being fueled by apathetic doctors practicing apathetic medicine. And it's given rise to the social media influencer that can actually be a health coach with no formal medical training and get patients healthier. It's given rise to cash-based and concierge clinics that are doing a great job at keeping people healthy and maintaining quality of life. Regenerative medicine is a misnomer. You're not regenerating anything. It's really restorative medicine. You're trying to restore somebody their prior quality of life. If you have a heart attack, you didn't save somebody's life, right? You're trying to restore them to their prior quality of life before they had the heart attack. That's my personal argument. But I think this gives opportunity in your practice, in my practice, right? And in every successful doctor's practice, you find a similar paradigm. That it is quality of care that gets you busy.
Right.
And that quality of care is predicated on the outcome. Right? If you have great outcomes, you're going to be crushed busy. Right. Somebody that has terrible outcomes, that has a terrible, even if you have an awful bedside manner, if your outcomes are good, right, people will go to see you and they'll know this guy has a terrible bedside manner. He's awful to talk to. Well, you know what? You don't want to be great friends with your doctor. If you're seeing your doctor all the time, you're not out doing all the stuff you should be doing, right? Right. You don't want to see your spine surgeon all the time. If you're seeing your spine surgeon all the time, you've had a lot of surgery. Right. Right. You want to see your spine surgeon one time and then never see him again. And maybe, pass him on the golf course or, whatever, see him at a restaurant.
Totally agree. So one last question that I have for you before we wrap up, and I really appreciate this discussion. I thought it was fantastic, but do you have any knowledge of glucopuncture? The use of D5W. We've been looking into this really for the last year, and we were used to a lot of D5W neural hydrodissections for the last probably 3 years now. I've been fortunate enough to have Jan Kershaw from Belgium on the show, and we're seeing pretty incredible results with it. From it's simple, it's cheap, it's almost without side effect, and it clearly, in our experience, has been far better than steroids ever were, as far as the different uses. Now, we haven't used it a lot intra-articularly, but any thoughts on that?
And you're using it for hydrodissection of what? For nerves?
Yeah, for nerves. So let's say if I have a tarsal tunnel situation, we'll use it on the tibial nerve. We'll use it on the confibular, confernular. We'll use it in areas where, let's say there was a skin graft, and it's an area where there's a lot of nerves that are entrapped underneath that skin graft, and you just don't want to go mess with that because surgically, they may never get that thing to heal in here. So we'll infiltrate just subcutaneously D5W, and within a matter of seconds, they'll say, all the pain's gone. Now, that doesn't stay that way. You have to repeat it for a period of time. You're not going to hurt anybody with it. But I think there's some real merit.
Well, I mean, it makes sense, right? I mean, where I'd really be interested is what happens if you actually put collagen growth factors in with the D5W. Now, do you get dual magic, right?
Yeah,
right. Because when you're doing hydrodissection of a nerve, right? Nerves, especially the tiny little nerves, right? That are in the bottom of the feet and everything else. Everyone forgets that the nerves need blood supply as well. Sure. They also need glucose, right?
Yes,
and so the vasa nuvorum, the nerves that are, the blood vessels that are supplying the nerves.
Right.
Those blood vessels are what are nourishing the nerves.
Right.
And if you have peripheral vascular disease, you don't get much blood supply to those nerves. And if you don't get blood supply to the nerves don't get any nourishment. They don't get any sugar. They need glucose, right?
That's right.
And so if you do a little hydrodissection with a little bit of D5W, it's kind of like giving Gatorade to somebody who just worked out, right?
Right.
It's going to give them those essential minerals and, the essential building blocks to kind of perk up a little bit.
Right.
And that's good, right?
Right.
I'd be terribly curious to see what would happen if you added collagen growth factors that would accelerate chondral differentiation with that hydrodissection with D5W. Does that potentiate the effect of the D5W? Because the D5W works for a little while, and while that nerve is kind of in the process of healing itself, while the body's in the process of healing, it's going to go through some element of healing. And as opposed to going through a fibrin-based healing process, which is what's going to be in the area, fibrin, what happens if there's collagen growth factors in the area and it can go through chondral differentiation while it's got all this nourishment to be able to do that?
I think that there's a lot of future research that's going to address that specific question that you just asked about combining of the different types of therapy. And my rudimentary knowledge now is that there's no harm with that. I know that there are people that are using it in conjunction with PRP. I think that there may not be a lot of randomized prospective trials because D5W is now a patentable drug. And so, where's the commerce impetus behind that? So I think that's one of the big drawbacks of it. But I think it's something that, at least it's not going to have the negative effects of a steroid. And there's been a couple of articles published, one on carpal tunnel, but it is relatively recent, where they actually show that it was far superior to steroid injections. And I've always used steroids very judiciously, but we've always known the negative side effects of it. So I think this is
1,000%.
Yeah. So this is something that I think has a great future for pain management because it's very safe.
I love it.
It's very simple. But I'll try to get you in contact with Jan Kirschap because I think you'd love to chat with him. He's brilliant.
No, that'd be fascinating. It'd be fascinating.
He's going all over the world now, training all different specialties because this can be administered, the glucopuncture, without any ultrasound guidance. So in impoverished countries, it's very easy to get this treatment out there for a lot of people without side effects. So,
sure, and cost effective. Very cost effective.
Yeah, very cost effective.
Well, and I think just to leave it on that note is an important thing, right? Who is going to move medicine forward? It's got to be the doctor in the clinic. It's got to be just the simple doctor who decides that he's had enough with what Big Pharma is telling them, and that he's going to do the hard work to do his own observational study, not randomized double-blind placebo-controlled trial, because those are all drug trials, right? And you're going to come up against the FDA. Just a simple observational study.
Right.
I did this. I did at least 30 patients, so I have enough patients to power a study, and this is what I found. I think everyone forgets that the measure of a good study is the duplicity of the study. Can it be duplicated? Right? Can I see those same results in my practice with my patients?
Exactly.
And so many drug studies aren't duplicable. They just throw a drug in your face and say, here's a study. Well, you don't see those results in your own practice, right? But something simple, something observational, 30 patients, it doesn't cost that much. It isn't that hard, to get a paper published. I know, I did it a bunch.
Right.
But you have to decide that you want to do it. And so anybody watching this, just sitting on the shelf, right? Or sitting on the bench thinking, I don't really want to do that. I'm going to give you an interesting statistic. Of the people that decide that they want to write a book, less than 1% actually write a book.
Right.
And even fewer actually take it to publication. Well, I would bet that those same numbers are true for people who want to publish a paper.
Well, I think if you look
that
at
there are probably fewer than.
Yeah, what I was going to say, I think if you look at any specialty and you took 1,000 people from that specialty, it's a very, very small number that even have 1 or 2 publications, let alone 10 publications.
Correct.
It's again.
Correct.
I've written several books. I can tell you it's a very lengthy process, and it sucks a lot of life out of you. It's not something that is just falling off the log easy. It's an arduous process, and so anybody that publishes and does this type of work, I have great respect for. But I think you're absolutely
well. But I think it's important to remember that all of your lived experience and all of my lived experience and all of your clinical training and knowledge and all of my clinical training and knowledge is eventually going to go away.
Mm-hmm.
How will that be passed down to the next generation of podiatrist or pain doctor or regenerative medicine doctor? The only way that knowledge gets passed is published work. It's the only way it gets passed.
Well, and formal.
And so
we have a formal NERD fellowship program where we're passing stuff down to one person every year. But
I love that. But
you're right.
That doesn't exist in most specialties, right? But even within that fellowship, right? What's the literature that you're going to base that fellowship on other than clinical training? There's got to be something published to hang your hat on, right?
Right.
Because you got to show receipts.
Right.
And your receipts in this medical marketplace are published studies. So, this is just me talking to everybody that's out there, right, who might be listening to this. If you even have the most remote inkling that you want to do something and you want to get something published, certainly reach out to me. I've taken, 10, 12 articles to publication in the past 24 months. I can certainly be of help because there are people doing great work out there that they're getting amazing results. They're dramatically improving the quality of people's lives.
Right. And
we need more of that. We need more exposure to that in a way that people can wrap their hands around.
Yeah, I agree 100% with you, Dr. Martin. How do people get a hold of you? I would put it in the show notes, but what's the best way for them to reach out? Do you have a website that they can go to?
Sure. Yeah. Well, my medical practice is Live Beautiful, liv-beautiful.com. And certainly you can get a hold of me at my office. That's one of the easiest ways. I'm not going to give my cell phone number because that'll be awful. But one of the companies that I do consult for is Platinum Biologics. And if you want to give an email, scott@platinumbiologics.com, that's one of my emails that I don't get spam on. And so that email will go through.
Perfect. Scott, thank you so much for your time, your dedication to making people better. And I really appreciate it. I look forward to having many more conversations with you.
Absolute delight speaking with you this morning. Have a blessed day.
Thanks.
Before we continue with this great discussion, I just want to take a quick break to acknowledge this week's sponsor. This episode is sponsored by Savant Cellars, providers of boutique Tier 1 Reds at a Tier 2 price point. Let's imagine you are spelunking in a cave out in Napa Valley, and you come across some of the juice from Savant Cellars. You may just never want to come out until it's gone. Savant Cellars sources all of their fruit from the really big-name boutique vineyards. That's right, where the elites get their fruit. If we put a vineyard designation on our bottles, we would be contractually forced to sell our wines at 3 to 4 times our current pricing. Yes, full disclosure, I am one of the 3 principals and I'm very proud of our wines. Savant Cellars is the genius of wine. Simply great wines, vintage after vintage, crafted in a Bordeaux style so you can lay them down for years or drink them now. They simply just get better. Use the code SPELUNK15 to get a 15% discount at savantcellars.com. That is CEVANT sellers.com. Spelunk15.
We hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes, found at our website, potofinquiry.com. If this incredible and educational conversation has tickled just a little bit of your cortex, please leave us a review and spread the message to your friends and colleagues. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show and used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.